Case number 20. A 39-year-old parous female came with a painful left breast mass associated with skin erythema and sinuses and nipple discharge and inversion. Left breast mammogram revealed asymmetry. Ultrasound revealed an irregular mass with shadowing. Incisional biopsy was taken. Microscopic examination. These micrographs demonstrate benign terminal duct lobular units, lobulocentric lymphoplasmacytic inflammation with fibrosis within and around lobules, round to oval cystic spaces, lipid vacuoles. These micrographs demonstrate lobulocentric granulomatous inflammation, obliterating lobulocentric distribution, a background of multinucleated giant cells, lymphocytes, plasma cells, and eosinophils within and around lobules. Round to oval cystic spaces, lipid vacuoles covered by neutrophils and non-necrotizing granulomas. Multinucleated giant cell with Schaumann and asteroid bodies. These micrographs demonstrate lobulocentric granulomatous inflammation, multinucleated giant cells containing Schaumann and asteroid bodies, lymphocytes, plasma cells, and eosinophils within and around lobules, an oval cystic space, lipid vacuole surrounded by an uncaseating epithelioid granuloma. These micrographs demonstrate non-caseating epithelioid granulomas with central lipid vacuoles consistent with dissolved lipid rimmed by neutrophils, microabscesses. A background of mixed inflammation including lymphocytes, plasma cells, and eosinophils. These micrographs demonstrate non-necrotizing granulomas comprised of epithelioid histiocytes and multinucleated giant cells, central many neutrophils, microabscesses, neutrophilic granulomatous inflammation, lymphocytes, plasma cells, and eosinophils within and around the epithelioid granulomas, lipid vacuoles. These two micrographs demonstrate non-necrotizing granulomas comprised of epithelioid histiocytes and multinucleated giant cells, mixed inflammatory cells in the background. These micrographs demonstrate dilated ducts with apocrine metaplasia containing multinucleated giant cells, lymphocytes, plasma cells, and eosinophils, along with fibrosis around the dilated ducts, round to oval cystic spaces consistent with dissolved lipid. These two micrographs demonstrate diffuse infiltration by lymphocytes, plasma cells, and eosinophils, foamy and epithelioid histiocytes, along with multinucleated giant cells, poorly formed epithelioid granulomas, loss of lobulocentric distribution. Okay, what is the diagnosis? It is cystic neutrophilic granulomatous mastitis. Terminology not recommended. Granulomatous mastitis, idiopathic granulomatous mastitis, granulomatous lobular mastitis, idiopathic lobular granulomatous mastitis. Differential diagnosis includes tuberculous mastitis. It shows typical necrotizing granulomas and a positivity for AFB, foreign body reaction, fat necrosis, granulomatosis with polyangiitis. It shows positivity for P. ANCA and C. ANCA and prominent vasculitis. Sarcoidosis, granulomatous lobular mastitis. It is a diagnosis of exclusion without known etiology. Subareolar breast abscess. It is strongly associated with smoking and anaerobic organisms. Okay, let's talk about cystic neutrophilic granulomatous mastitis. General background. It is a rare inflammatory process of the breast. It is associated with Corynebacterium species, although microbiologic evidence can be difficult to obtain. Most patients are women, parous, or currently pregnant. Mean age is 35 years, range 19 to 57. It is usually unilateral. Approximately 8.5% present with bilateral disease. Clinical presentation. Most commonly painful breast mass, nipple inversion, or sinus formation. Nipple discharge, skin erythema and abscess. Fever and leukocytosis. Axillary lymphadenopathy. Mammography shows a mass or asymmetry, most commonly by rats for suspicious of malignancy. Special studies for cystic neutrophilic granulomatous mastitis. Gram stain shows gram-positive bacilli, rod-like structures within lipid vacuoles. Corynebacteria may be difficult to detect and culture. Corynebacterium species require culture medium containing 1% polysorbate and longer incubation periods. Alternative methods include matrix-assisted laser desorption, ionization time of flight mass spectrometry. Treatment. Prolonged weeks to months antibiotic therapy is required for complete resolution. Lipophilic antibiotics such as doxycycline and rifampicin may be more effective. Antibiotic susceptibility tests should be performed. Steroids may be added. Surgery including incision and drainage, excision, and even mastectomy. Combination of the above therapies could be required. It may recur with inadequate therapy. These are the references. Thank you.